Hey everyone, welcome to the June Roundtable, and we're going to be covering the foot and ankle this month, all month of June, and I'm really excited about that because I've been seeing a ton of foot and ankle injuries recently, that from plantar fasciitis to complete dislocations, which are pretty crazy to see and treat. And I know we're all pretty excited about different topics we have for it. Chris, you know what you're going to be talking about in June?
Yeah, I'm planning on writing a little bit about how we can work on diagnosing ankle and foot injuries, specifically fractures, and then how to manage it from when they first have the injury. If they were to walk into our office, direct access, or if they've already seen the doctor and possibly they've had some imaging done, maybe they've had to have surgery, or maybe it's just require a boot or something. But I go into some detail about that, just the progression from day one to return to prior level of function.
Get into some like Ottawa foot and ankle rules.
Exactly. Yeah.
Nice.
Mhm.
Brian, what about you? You know what you're getting into?
Yeah, I'm going to be talking a little bit more about differential diagnosis with lateral ankle sprains. And the reason why that is in my head right now is it's basketball off season, and I've seen some interesting cases, cuboid syndrome cases, as well as some peroneal strains in addition to lateral ankle sprains. And I think that's something that is often missed or forgotten about because lateral ankle sprains are so common. And, I'm going to be talking a little bit more about load management with those return to sport with the cuboid management. So, it'll be an interesting topic. I think a lot of people will like it.
Definitely. I know I put out a post a long time ago that was on lateral ankle sprains and different neural tension. So a lot of times people get better, like 90% better after an ankle sprain, but they still have some residual symptoms, and it ends up being some neural tension along the outer ankle.
Yeah, that's another good one.
Mm-hmm.
I actually had this patient just this past week that I evaluated that kind of fell into that category, Jim. He had some ankle sprain probably a couple months ago, and presenting with anterior impingement of the talocrural joint, but along with that,
Like
say that again?
he would feel it when he was in dorsiflexion then?
And with plantar flexion, though. So I did a little neural tensioning and found the superficial peroneal nerve to be involved and positive with that tensioning. So it's going to be a fun case, working a little bit with the lumbar spine and working the local joints as well, just because there is some joint restrictions from it.
I actually saw a guy that had, you were talking about fractures earlier,
Mm-hmm.
and I had a guy recently this was a gentleman young guy playing basketball, dislocated his ankle, and he was in a boot for, I think, 8 weeks afterwards. And he actually had complete big toe or second toe numbness, more from the deep peroneal nerve. So it's just interesting how someone wears a boot for 6 or 8 weeks and they wonder why they have some of this numbness. Take away the external interface that's causing it, and sometimes the symptoms go away.
Yeah, do you think some of it was just the compression up near the fibular head?
It was not as much along fibular head. I couldn't reproduce it anywhere until I would provide some neural tension and give pressure more like in the midfoot area.
Mm-hmm.
That was the only time I could reproduce it. And he's like, "Oh, there's my neural symptoms. There's my numbness."
Yeah, and did you see him after he was out of the boot, or was it more so just like it was during? And did you have to make any boot modifications?
I actually didn't make any. He started noticing the numbness like when he had 1 week left of wearing the
Ah,
boot. And so I was like, we'll just get out of it. Like if you're going to be out of it next week, just start wearing it less.
out of curiosity for you guys, do you typically try and work the like all the way up to the spine with those cases, or do you try and keep it more local to like the foot, ankle, maybe the fibular head region?
Brian, do you want to chime in on that one?
Yeah, I always look at lumbar spine, and I think that that's something that, we've always talked about internally ourselves that is so crucial. The lumbar spine is something that I see with almost every single one of my foot and ankle patients. And, there's a thought, it starts from the bottom up, but maybe it's top down. I don't really know. All I know is that if they have something foot and ankle related, I'm definitely looking up the chain, and I'm definitely looking as high up as the lumbar spine, and sometimes even the shoulder. And it takes a little bit more time, but it seems to really clean up a lot of stuff later on in the treatment when they're actually getting better. Because if we don't clean that stuff up early on in the process, then they're missing some of these fundamental components for when we're actually returning them to more functional things.
Yeah, and like you said, it takes a lot of time, and it does take time. But I know like what we hit on a ton in Insider Access is kind of the looking at all the different regions of the body and quickly assessing different regions. Like my video on how to just quickly do cardinal plane active range of motion and what you should look for. Sometimes, even though like it seems like it takes a long time, and for you and I, probably for the assessment only takes 30 seconds maybe, and then the treatment and education is what takes longer. So,
No, you're 100% right, and I think that when I say it takes longer, it's if you want to be more thorough, you definitely can. And
yeah, absolutely, I know what you're.
There's times where you do it quicker, and that's what makes the treatment a little bit more effective too.
Mm-hmm. But I'm sure, like in all your golfers and basketball players who need to be able to disassociate between upper body, lower body, that's huge.
Especially the taller players, every single basketball player, because they're so tall, their torsos, you have to look at the lumbar spine. You are missing the boat completely if you are just looking at the feet, because they have so many issues, even in the cervical spine, because they're looking down at people the whole time because they're so tall. So you have to look at these bigger extremities as well.
I think that component's huge. Like my guy, he's 16 years old, he's 6'7". He probably grew like a foot in the last year. So I mean, it's just like that height component and not being able to control kind of things are just further away at that point too. So you need to make sure upper body is communicating with lower body.
Well, I think just going off the basics too of the fact that if they are in a boot or they were in a boot, I mean that's all of a sudden you're adding like an inch or two leg length discrepancy. Not that I think leg length discrepancy is a big issue, but that is an abnormal stimulus to the spine or to the nervous system all of a sudden that very very possibly could impact the spine and neural component coming centrally, which then has the peripheral effect as well, making them potentially more prone to any sort of neural symptoms in the leg. So anytime there's like a chronicity presentation with a symptom, you always got to think, well, maybe we should check the spine anyway.
Yeah,
I'll go ahead, Brian.
I was gonna say, for those of you guys that are watching this right now, we have a ton of articles as well as videos on this stuff, just even on our regular website, in addition to Insider Access. So if you guys are wondering, what the heck are you guys talking about with some of this nerve stuff, look at some of our articles. We have some awesome information on that, because I know that for a while there, I was completely lost with that stuff before I started really understanding it. So.
And I'm making a note right now. I'm going to put a bunch of those nerve articles in our next newsletter too, just so people have access to those.
Yeah, great.
Yeah, and I think also, Chris, what you said about just you're putting this new boot that's maybe an inch or two difference all of a sudden, because the biggest thing with that is that they don't have the tissue hasn't had time to adapt to the amount of stress. You guys know Veronica's pregnant right now. I think about that all the time, why pregnant women get all this pain. And it's probably because of the excessive amount of change in such a quick time. Like she put on 25 pounds in just a few months. So it's like, and that's a small example. Women put on 50 to 60 pounds. It's just like a change for the body in a short amount of time. So like you don't have time to adapt to some of that stress. Then you take hormonal changes and all that other stuff. It's just interesting.
Oh yeah, absolutely. And yeah, yeah, and of course we have to consider like the other things going on in their life, like you said, hormonal or job restrictions, whatever. Brian's case, you have an athlete that needs to return to work. I mean, it's the whole body. Got to consider it.
Hey, where do you guys start with assessments when you do foot and ankle?
Well, I'm pretty standardized with my evaluations. Like my basically like lumbar body down, I do pretty much the exact same evaluation, check some lumbar spine mobility, hip mobility, knee, ankle. The difference comes for me for sure when I'm looking at specific movements for how they're moving in that area, and then segmental mobility testing and neural tensioning. But I mean, my exam starts in the lumbar spine and will move down for almost every single foot and ankle patient.
Very similar with me, Chris. And then also, I really look at, and this is what I'm going to be talking about this month, and I made the Insider Access video this month for this thing too, is kind of how looking at the foot and more than just a one-dimensional plane. So instead of just looking at the foot and ankle as plantar flexion, dorsiflexion, stressing all different parts of the foot and ankle. So loading medially, loading laterally, looking at subtalar joint mechanics, because the foot and ankle is so three-dimensional that we have to be, maybe they can handle plantar flexion and dorsiflexion, but they can't. A slight deviation medially is when they have pain. And those are the things that I think are interesting to look at. What about you?
It depends on the way they're presenting. And the reason why I'm asking this is because I will start my assessment differently if they're presenting with something medially versus laterally versus anteriorly or posteriorly. However, the one thing that I think has changed for my practice over the last at least year or two is how much load I'm putting them through, depending on what they're presenting with. Because I've seen over time that load is changing their mechanics completely. And Jim, that is something you talk about in your Insider Access too, is just looking at foot positioning when it's loaded versus unloaded. And I think it's something that has really changed my treatment practice as well as assessment. So again, it depends, and that's not a really good answer, but load is something I've looked at.
Interesting. So how do you alter or change the load? Is it like you put them on a different level over the total gym, or get them in a pool?
That's one of the things if you have access to an Alter G, I like to use that a lot. Otherwise, I will, instead of just having them just walk or go through things like that, I will have them go on like a stepper, or I'll have them go into a lunge position, things like that, which is going to change their load unilaterally versus bilaterally, for example.
Nice. Well, do you want to close with anything else on this one?
No, I can't say anything specific other than, looking forward to seeing all the articles coming out this month and getting a good read in.
Absolutely. Brian, any closing thoughts from you?
No, I just think that, if you guys that are watching this have any questions or have different ways that, you want to ask, how do I assess, how do I treat, feel free to email us, because, we have these roundtable discussions and we always learn something doing that too. So ask questions and throw out some comments so we can help you guys.
Mm-hmm. Well, June 2018 is all about the foot and ankle, so stay tuned this whole month. We're excited. See ya.